Hello, my name is Ruben Mesa, and I'm the Executive Director of the Atrium Health Wake Forest Baptist Comprehensive Cancer Center. And delighted to be joined by this wonderful panel of experts in myeloproliferative neoplasms for us to take a deep dive in myelofibrosis. We're grateful to Blood Cancer Today for us to be able to share with you some of the exciting updates on the diagnosis and therapy of patients with myelofibrosis. So now in 2024, we have 4 FDA-approved JAK inhibitors in the United States. We have ruxolitinib that has a fairly wide label, platelets over 50,000. We have fedratinib that has a similarly fairly wide label. We have pacritinib for patients with thrombocytopenia, particularly under 50,000. There's clearly data between 50 and 100,000 for platelets and can help with anemia. And momelotinib that has a broad label for MF patients kind of with anemia. So let's get into some of their usage. And let's, again, start with that first line. Mm-hmm. You know, we've decided that they're going to go on a JAK inhibitor. You know, let me put it this way. In whom do we start ruxolitinib, and whom do we choose one of the other 3 agents? So Toyosi, how about yourself? Who's kind of your slam dunk? This is a Rux patient versus I'm going to do something perhaps a little different.
Yeah. So a Rux patient for me would be a patient that walks in, has that, splenomegaly, constitutional symptoms, the typical patient for whom we would love to be able to start a JAK inhibitor, and that has still relatively well-preserved hematopoiesis. So with ruxolitinib therapy, we can expect, sort of a drop in hemoglobin that's somewhere in the range of 1.5 to maybe 2 grams around the 6 to 8 week mark, and with then a little bit of recovery, maybe not all the way back to baseline. So if somebody walks into my clinic and is already significantly anemic, teetering on the verge of maybe soon to be needing blood transfusions, I don't instinctively reach for ruxolitinib. But somebody who, say, comes in with a hemoglobin of 11 or 12, but their spleen is big, they're losing weight, they feel really crummy, to me, that's a perfect patient for ruxolitinib therapy.
Wonderful. And let's limit this to Rux just to begin with, and we'll take each of them in turn. Yeah. Naveen, what would you add? Again, slam dunk, walk in, Rux all the way.
I agree with everything both you and Toyosi said. It's amazing that it comes down to the cytopenias, the blood counts. It is exactly what you both said. So platelets above 50, below 50. If you're below 50, I'm reaching for the newer agents, including the pacritinib, which has the frontline indication. But you have to have platelets above 50. And I love what you said about the anemia. Traditionally, we didn't necessarily use that as a marker because we only had the Rux agent. So let me say that if you have severe anemia or thrombocytopenia, that's the person I'm not selecting Rux for in the frontline setting.
I would add that, I think everyone's kind of fair game who doesn't have severe cytopenias. However, the group that is, for me, the biggest slam dunk, post-PV and JAK2 mutated. That's a group that, again and again, we've seen bigger spleen, more symptoms, higher counts, but post-PV MF patients, they just don't tend to be as anemic. I think in part because they still preserve some intrinsic kind of erythrocytosis is still kind of fighting to get out there and such. Including game in all of them. Yeah. But that's always been the group that, it's just like, a fish to water. It just thrives kind of in that setting. Mm-hmm. Now, Sanam, as we clearly now have, more than a decade of experience, with follow-up bone marrows on patients who've been on Rux, what sort of things do you typically see? Are there kind of signs that you see from the marrow that are that you would correlate with response or lack of response?
Not really, unfortunately. We don't really see a resolution of fibrosis. We don't really see I would say the converse is probably true. So if we start seeing dysplasia, morphologic dysplasia, that usually correlates with, progression of disease, clonal evolution of disease. But, in terms of what we do see worsening of the fibrosis in patients that are progressing. We do see osteosclerosis in patients that are progressing. But, to just look at a bone marrow and say, oh, I bet this patient's doing much better on the therapy, that's really not something that, we can tell morphologically. I do have a question for you, though, and this just occurred to my mind when you told us about the post-PVMF.
Yeah.
So today in your clinic, because we struggle, over this a lot, is let's say someone comes to MD Anderson and they say, this patient has a long history of ET. And they come and I look at the bone marrow and it's completely fibrotic now. Morphologically, I can't tell. Does that make a difference to you? Does a fibrotic primary myelofibrosis, does that change your treatment versus a post-PV or a post-ET myelofibrosis?
Not to any significant degree.
Right.
I'd say post-PVMF is the cleanest because there's typically a history. They were JAK2, they were diagnosed with PV, they had phlebotomies, they stopped needing phlebotomies.
Yeah.
We saw the progression. The post-ETMF is very messy because many of those, you really wonder, do they have MF the whole time?
Yeah, absolutely.
Right.
Yeah.
Was
Was it a pre-fibrotic?
Pre-fibrotic.
Yeah, was there a baseline bone marrow?
Right.
Absolutely.
So I view that ET and MF are kind of this awkward kind of yin and yang, with PV kind of having its own kind of very distinct, distinct arc, And again, I think over time we'll have more differentiation between JAK2 mutated disease, and CALR mutated disease, particularly as our therapies start to differentiate to kind of a greater degree. So before we move on from RUX, dealing with complications from RUX. Anything big on your guys' mind? I know on my end, some of the ones I found to be trickier than obviously the cytopenias have been particularly the non-melanoma skin cancers, or kind of recurring herpes zoster infection. But Naveen, things for you that you have found to say, boy, they had this, this is a real deal killer. We really need to be moving on from RUX because of this toxicity.
One of the ones that's emerging in the clinic that I personally had missed was weight gain with ruxolitinib. I think it's, as we've been treating patients earlier and earlier, particularly PV post-hydroxyurea, so on-label indication in PV, the weight gain is notable for a couple of reasons. One, it can be rapid. I'm talking about some patients, 20, 30, 40 pounds. Two, our colleague Joe Scandura and others have done some studies that maybe there's some pathways, leptin, some of these adipose tissue pathways. And three, of interest, we're already worried about atherosclerotic, thrombotic events, cardiovascular. And so you have patients who certainly, a subset who need the weight gain. Those are some of our later stage myelofibrosis patients. You have a subset of patients who certainly do not need that. And I think I've added that to my counseling along with non-melanoma skin cancer, so basal cell squamous cell, and the herpes zoster or opportunistic infections. And I want to say that almost all of my patients now are seeing a dermatologist at some point. This is actually a real issue. So I'm either trying to get a baseline screening or at least mentioning this. I think it's a very important point you bring up.